Postmortem lesions and diagnosis of hemoptysis, PCD in case of sheep and goats. Theileria, Babesia, Anaplasma. These are very common diseases that can be observed in the field condition. Trypanosoma is a little bit rare. All these three diseases, Theileria, Babesia, Anaplasma, they are get transmitted by the different types of the ticks. That is Rhipicephalus, Hiloma, and mechanical transmission is also there in case of Theileria. Similarly, in case of Babesia, Buphilis, and mechanical transmission known to observe. Then the major pathological observation that can be observed in Theileria is extravascular hemolysis. RBCs get infected and get removed from the circulation via the MPS system of the spleen. In case of Babesia, there is a intravascular hemolysis. Whatever the parasites are there, parasitemia is there. In that case, the RBCs get lysed, and that simply it is called as a intravascular hemolysis. Then Anaplasma, it is it causes the extravascular hemolysis similar to Theileria. So the infected RBCs will go to the spleen and get scavenged in the spleen tissues. Trypanosoma is rarely observed, and mainly the pathological conditions which observed in the trypanosoma is hypoglycemia and rarely intravascular hemolysis in case of the severe cases of trypanosoma. One of the characteristic features which can be observed in the Theileria is the presence of punch type of ulcers in abomasum. That is present only in case of Theileria, which it is absent in Babesia, absent in Anaplasma, absent in Trypanosoma. Spleen enlargement, maximum it can be present in Theileria, in case of Babesia also, and in Anaplasma also. But in case of Trypanosoma, there is no enlargement of the spleen. Then enlargement of lymph nodes can be present in case of Theileria, Anaplasma, and Trypanosoma. But in case of Babesia, we are not getting that much of the enlargement of the lymph nodes. Icterus is present in almost all conditions. It is very intensely present in case of Theileria, in case of Babesia also, and Anaplasma. Lung edema, it's present because wherever there is an anemia, we can see there is a lung edema which can be present in Anaplasma, then Trypanosoma, as well as regularly we can see observed in the Theileria and Babesia. Mucous membranes are icteric and pale. In case of Babesia, they are reddish and icteric. In Anaplasma, they are purely icteric, and in case of Trypanosoma, it's based on the acuteness of disease, it is variable. Multifocal necrosis, in case of Theileria, it is present, absent in Babesia, absent in Anaplasma, absent in Trypanosoma. Color of kidney is yellowish in case of Theileria. Dark or black brown color or chocolate color can be observed in case of Babesia, along with presence of hemolyzed type of urine or the reddish type of urine in the renal pelvis. In case of Anaplasma, it's a yellowish type of urine can be observed, and in Trypanosoma, variable lesions can be observed in the kidney, or most of the times unnoticed type of lesions they are noticed in case of kidney, in case of Trypanosoma. Then body fluids, it is yellowish in case of Theileria, reddish in case of Babesia, yellow in Anaplasma, and variable in Trypanosoma. Now, the another comparison, the incidence, Theileria is very common, Babesia is common, Anaplasma is common, Trypanosoma incidence is rare. Acuteness of disease is observed in case of Theileria, in Babesia, and Anaplasma also. In Anaplasma, it's variable. Trypanosoma is also variable. Subclinical infection is very common in case of Theileria, Babesia, and Anaplasma. Then mixed type of infection, many times it was observed that the single animal or the same animal is get infected by Babesia and Theileria together, and many times, or the almost 90% cases will have the combination of Theileria and Anaplasma together. So there are chances of mixed type of infection in case of sheep and goat. Now we see some theoretical aspect of the Theileria in case of sheep and goats. So basically, etiology, it's a Theileria hilsii and Theileria ovis. These are the two species of Theileria that can be observed in sheep and goat. Transmission, it is mostly tick-borne infection, and direct seeding by the needles from the infected animals to the healthy one, it is possible. Mechanical transmission by some blood-sucking flies also present. Then transplacental infection is observed in case of the pregnant animals. Predisposing factor, as usual, these are the predisposing factor. They are common for the all three type of diseases. That is a stress, mainly the transportation stress, grazing stress, environmental stress, release of cortisol that lead to the immunosuppression. Then the surface antibodies get lost, and almost the upper respiratory tract get infected. Overcrowding is there, wormload is there, visiting transient flocks are there. Whenever there is a zero grazing type of animals are there, some other visitors animals come around the vicinity of that farm. Sometimes they will share the ticks over there, and that ticks will go to our farm, and that lead to the infection to our flock. Then hot and humid climate, hot and dry climate is also responsible for the increase the population of the ticks, and which can lead to the extensive outbreak of the ticks, we can say, and lead to the more number of cases of Theileria, Anaplasma, and Babesia during this phase. Then cracks in walls, mangers of the feeders, shelters. These are the places which where there is a hiding of ticks can be observed, and that lead to again number of progenies in the particular farm, because of there is a presence of cracks and crevices in the wall of that particular farm. Then presence of ticks on trees, shrubs, barks of the tree. Whenever there is a grazing type of animals are there, they generally peoples will go to the or the animals will go for the grazing, and ultimately the ticks from that different small shrubs or trees, barks will get infected to the body of the sheep and goat, and ultimately there is a chances of infection. Now this is the life cycle. Almost the two types of the simple two fundas are there. So in the live animal and in the tick. So most of the parts of the Theileria or the progeny or the, we can say, the different stages of Theileria, they are observed in the ticks, and they will come to the salivary gland. After that, the sporozoites are released. The sporozoite will go to the lymph nodes and will go to the lymphocyte, and there is a formation of cyzones, and these cyzones get again multiply. Merogony is observed, and merozoites are released, and these merozoites will go to the RBCs, and that we call as the pyroplasm. Then this same pyroplasm will be consumed by the ticks, and the further life cycle of the Theileria is continuously going on. So we are going to observe this stage in case of our regular blood smear examination. That is, the pyroplasm in the erythrocytes are visible on our blood smear examination. So this is about a little bit about the life cycle of Theileria. Now, pathogenesis, first there will be the attachment of ticks, then there is a release of cyzones from the mouth parts of the ticks, then they will reach to the local lymph nodes, then B and T lymphocytes will be affected, cyzones will multiply in the lymphocytes, then proliferation of lymphocytes, the clonal expansion of infected lymphocytes, then merogony observed, merozoites are released, and there is a release of pyroplasm in blood circulation. They will cause infection to the RBC, and various stages of the pyroplasm that can be noticed in the regular blood smear examination that lead to the parasitemia. After parasitemia, once the RBCs are infected RBCs will be removed by the MPS system of the spleen and lymph nodes. There is a progressive anemia, jaundice, decreased colloidal osmotic pressure that lead to the edema of the various parts of body, including lung tissues. Then secondary complications like pneumonia, hypoxia. Then there is a severe tissue hypoxia. Then there is an interstitial edema. Immunosuppression is there. Then there is a damage to the vascular endothelial cells due to the liver dysfunction, and there is a release of cytokinins. Again, there is a development of the abomasal ulceration, bleeding through the abomasum, and melena is one of the clinical signs that can be observed in case of the Theileria. Ultimately, all this condition leads to the severe anemia, and finally, there is a death of the animal due to the hypoxemia. Clinical signs, there are certain different types of clinical signs are observed. That is acute one, chronic one, and subclinical. The acute Theileria is characterized by the high fever, respiratory distress, then prodesalivation, icteric mucous membrane, selective anorexia. Colic will be there because of there is a development of the ulcers in the abomasum, punch type of ulcers in the abomasum. Then once there is a development of ulcers that lead to the bleeding into the abomasum, which lead to the melena. Sometimes there is a hard impacted fecal pellets are there. Then enlargement of superficial lymph nodes is another characteristic clinical signs that can be observed in case of all types of Theileria. Then because of anemia, there is a tachycardia. So these are the different clinical signs that can be observed in case of the acute form. In chronic form, there is an intermittent fever, respiratory distress is there, coughing is there, frothy salivation is also there, mucous membranes are ecteric one. There is a selective anorexia to the concentrate feed, colic is there, melena, hard impacted fecal material pellets are also there. Enlargement of superficial lymph node is also there, tachycardia is there, and continuous wasting is there. There is a decrease in a body score because the progressively hypoxia leads to the utilization of the some adipose tissues, and the finally there is a wasting of the animal is there. Now, subclinical theileria, it is characterized by the no fever. There is no absence of fever. Coughing is there, persistent coughing is there. Then the frothy salivation is obvious because of the edema of the lung tissues and anemia. Ecteric mucous membranes are there. Eyes are sunken. Selective anorexia is there. Enlargement of superficial lymph node is also there. Tachycardia is there. Progressive wasting. The animals are continuously wasting. They are losing their body score. Then unstressed, repeat bleeding, and prone to respiratory and digestive diseases. These are some of the other clinical signs that can be observed because of the subclinical type of theileria. So unstressed, repeat bleeding, and the progressive wasting. So these three things which can definitely affect the economy of the different farmers because of the subclinical theileria. Now, in case of clinical pathology, there is a mild anemia, moderate anemia, and severe anemia. 5 to 8 gram percent hemoglobin will be there in case of mild type of cases or the mild type of anemia. Then moderate will have 3 to 5 gram percent and hemoglobin, and in case of severe cases of theileria, there is a presence of less than 3 gram percent of the hemoglobin. Then there is an increase in serum bilirubin levels. SGPT will be high. Lymphocytosis is there. Thrombocytosis will be there, and presence of organism or the pyroplasm in blood smear. KBBs or the Koch blue bodies can be observed in case of the lymph node biopsies. So basically, on an average, we are observed the icterus is there, enlargement of lymph nodes, lung edema will be there, hemorrhages on the endocardium and epicardium. Then the liver necrosis and yellow discoloration of the liver is there, and variety of punch type of ulcers are observed. And these ulcers are based on the how we are going to deteriorate the case by giving the progressive doses or the continuous doses of the NSAID, that is the non-steroidal anti-inflammatory drugs. So that will exaggerate the ulcer intensity. Now we'll see the one by one, the ecteric adipose tissue. So everything will be ecteric in case of the hemoprotozoal disease. So there is a ecteric type of adipose tissues. Here again, we can see the intense ecteric type of adipose tissues. It's a little bit less icterus will be observed in the subcutaneous tissues as well as the some fascia and the especially elastic fibers, where the wherever the elastic fibers are there, they will take much more intense bilirubin color of the yellow coloration, discoloration. Here you can see there's some elastic fibers, the in between the whatever the elastic fibers they are joining the different body cavities will become the that much of icteric or the very yellow in color. Then enlargement of subscapular lymph nodes along with the icteric tissues. The icteric tissues are also there. Then there is a presence of the enlargement of lymph nodes. If you see, this is the enlargement of lymph nodes. This is also enlargement of lymph nodes, and along with that, whatever the tissues are there, they are icteric one. Again, here there is an enlargement of the lymph nodes. This series of lymph nodes is get enlarged, and you can see the whatever the adipose tissues which are present around the these lymph nodes are the suprascapular area or the scapular areas, they are becoming yellowish. Now there is a presence of epicardial hemorrhages. So as we discussed in earlier, hypoxia or hypoxemia lead to the damage to the vascular endothelial cells that lead to the rupture of small capillaries. So similar type of hemorrhages that can be observed over the epicardium. So epicardium will have the pinpoint hemorrhages, then endocardium will have the either pinpoint hemorrhages or the little bit ecchymotic type of hemorrhages can be observed in case of the endocardium. Then aorta, as we know, aorta is made up of the only or the maximum amount of the elastic fibers. It will show typical yellow discoloration. Again, the same thing, cut open aorta will have the yellowish discoloration because it is made up of the elastic fibers. Again, the same another case with the yellow discoloration of the aorta. Heart chambers are there. These heart chambers are made up of the chicken fat clot. So it's a observation that can, this type of observation generally observed in case of the severe anemic cases. But whatever the plasma is there, the plasma is become little bit extensively intense yellow in color. So this type of conditions will call as the we can say there is a typical jaundice type of blood, and the same blood is get clotted, and we are observing the chicken fat clot, and the color or the color of plasma will be intensely yellow, and this plasma will get clot, and we are observing this type of blood clots in the heart chambers which are having the extensive yellow discoloration. Then ulcerations can be observed from the surface or from the outside of the abomasum also. Then the lung edema, and many times it was observed that the froth which is present in the lung also, it is of yellow color. So lung edema along with the yellow color froth can be observed in the bronchi or in the tracheal lumen. Here this case is little bit we can say not that much of yellow in color, but having the lung edema. So the froth which is present in the lumen of trachea is a frothiness is there because of the lung edema. Then intense yellow coloration of the trachea in severe cases, we can say that icteric aorta trachea because of the presence of elastic fibers, as simple. Icteric subcutaneous tissue. So many times subcutaneous tissues and the facial material or the adipose tissues are also become a yellow in color because of the extensive jaundice, or we can say icteric. So subcutaneous tissues, fascia is there. Here again the some adipose tissues which are attached to the sternum, they are become the yellowish in color. Then multifocal necrosis can be observed in the liver tissues. So here we can see the small multifocal necrotic changes. Here little bit extensive type of necrotic changes that are observed in the liver tissues. Again the similar type of things. So extensive necrosis of the liver. Then there is a icteric kidney. The kidneys are become icteric, or the whatever the elastic fibers which are present in the hilus or the near the renal pelvis or the ureters, they become yellowish in color. So the kidneys become icteric, or the elastic fibers which are present in the kidney tissues, they are look very intensely yellow. Again the another case, so you can see the extensive yellow discoloration of the kidney tissues. Then abomasal hemorrhages. So from outside we can see the abomasum is look like a blackish, some black type of material that can be observed in the lumen of abomasum. And once we cut open, we can see the extensive blood loss and extensive type of hemorrhages are there. And whatever the acid is there in the abomasum, it get mixed with the hemoglobin, and there is a formation of acid hematine. And once there is a formation of acid hematine, which is of blackish or the tarry in color, or the black chocolate type of color is there, and that we call as a melena later on when such type of material is voided through the fecal material. So abomasal hemorrhages are there. Then these abomasum will show the variety of punch type of ulcers. So you can see extensive punch type of ulcers are present over here. So all the folds of the abomasums, they are having the punch type of variable size of the punch type of ulcers. Here again, the another case with this similar type of punch type of ulcer. So these some ulcers are combined together and they form a big ulcer. So small ulcers collide together and they form a bigger ulcer. So that also observed in many cases. Less intense cases, we can see there is a presence of punch type of ulcers, but they are scattered in the abomasum. So generally, this is the pyloric region. In the pyloric region, we are observing the different types of punch type of ulcers. These ulcers are like this. Some other cases will have the ulcerations. This type of ulcers generally in complications with the NSAIDs, so non-steroidal anti-inflammatory drugs, along with the thaleria. If the physicians or anyone, or the many times farmers are giving on their own once the fever is there, and without giving some H2 blockers, they are giving the antipyretic, anti-inflammatory drugs, and that lead to the damage to the mucosa of the abomasum, and the irregular type of ulcers are there. Along with that, we are observing the punch type of ulcer. They are present in the mucosa of the abomasum. Again, here we can see the another variety of the ulceration. So these are the again punch type of ulcer. They are observed in the mucosa of the abomasum. Here again, we can see these are the different punch type of ulcers. The small, they collect together or they combine together, irregular ulcerations they are observed. Here again, the deep ulcerations can be observed in the middle portion of the abomasum. In sometime or the variety of cases will show this type of ulcerations. Then in less infection or the less intensity cases, we are observing ulcers, very few amount of the few numbers of ulcers in the folds of abomasum. So here 3 pores are there, here 3 pores are there, like that. Very small quantity or the small number of ulcers, punch type of ulcers are also present in the folds of abomasum. Here again, very small numbers of ulcers, 1, 2, 3, 4. So here we need to observe abomasum very carefully. Here again, the rows of the abomasum, they combine together like this. So these type of ulceration, they are very commonly noticed in case of filariasis. Here again, we can see very few ulcers are there in case of some subclinical type of infections. Here again, another case of the filaria, which are having the rows of the filaria, rows of the ulcerations. So like this, different rows of the ulcerations, they are observed. This is a combination of the ulcerations along with the NSAID toxicity. So NSAID toxicity along with the ulcerations. It's also similar, hemorrhages and ulcerations, they are observed. So this is the punch type of ulcer, and here also punch type of ulcers, but these are the hemorrhages. And this type of observation, they are observed because of the complication of filaria along with the NSAID toxicities. Here again, long-standing ulcerations. Sometimes there is a healing of the ulcers by proliferation of some fibrous tissues in the abomasal folds. Then another peculiar findings after observation of the abomasum, we are observing that there is an enlargement of spleen. So there is a increase in the size of spleen by 2 or 3 times in case of the filaria. Now, diagnosis of filaria is based on the clinical signs, then hematological observation, biochemistry, then the lymph node aspiration biopsy, and simply staining with the Leishman stain. And we are going to observe the different types of KBBs. Then those farmers which are interested for the much more sophisticated techniques or the test, we can go for the ELISA. And if anybody wants some species identification or more than that, they can go further. Or basically we can say these are the academic type of test. So ELISA and PCR, these academic type of test, but at the field conditions, the hematology and lymph node aspiration will plays important role for the instant diagnosis of the filaria in case of sheep and goat. Then besides that, if the mortality is there, the postmortem is a basic or the best tool for the identification of different lesions of the filaria. So the clinical signs, hematology, biochemistry, lymph node aspiration, ELISA, PCR, and postmortem diagnosis or the postmortem examination are the diagnostic tools for the filaria in case of sheep and goat. Now these are the blood smears which are showing the little bit pyroplasms. They are present in the RBCs. So all these RBCs are infected with the pyroplasms. Here again, a little bit more number or more intense infection is there. So pyroplasms are present in the RBCs. Then KBBs, Koch blue bodies, they are observed in the lymph node aspiration. You can see the lymphocytes which are having the small scisons present in the cytoplasm. KBBs are also there. Here again the another type of KBBs, they are present in the lymphocytes. Complications of the filaria, most of the times filaria is complicated with anaplasma, Babesia, Ehrlichia, and due to multiple type of ticks present on the surface of the body. So means as the ticks, many or the variety of ticks are present on the surface of sheep and goat, that may lead to the presence of different types of hemoprotozoal in single case. Then another complication of the theileria is the pneumonia because of lung edema, and HS or the secondary bacterial complication can be observed. PPR may be concurrent infection in case of theileria. Then hepatic encephalopathy may be present because of the multifocal necrosis of the liver. Then enteric infections because of the more ammonia levels in case of the intestines. Then uremia is another complications of the theileria that can be observed in the field conditions. Now, treatment for theileria, no doubt I have given treatment at the last slide also. Specific treatment for theileria, we can go for the buparvacone at the rate 2.5 milligram per kg body weight, and to be repeated after 72 hours. Sometimes it may require it may require 2 to 3 doses of the buparvacone in case of the clinical and subclinical cases, because generally it was observed that the clinicians are giving the buparvacone for a single time, and then they will stop the another treatment, and it was observed that many times the buparvacone 2 or 3 doses of buparvacone are required for the treatment of the theileria in case of sheep and goats. Then oxytetracycline can be given at the dose rate of 5 milligrams to 10 milligrams per kg body weight intravenously. Then hematinic should be incorporated in the treatment. Then H2 blockers should be there because as we know, theileria will cause abomasal ulcers, and we should enhance the healing process of the abomasal ulceration by giving the H2 blockers like ranitidine or the omeprazole. Then hemostatic agents, whenever it is required, whenever we observe the melena or the little bit tarry colored discharge from the other tarry colored feces, in that case we should give hemostatic agents also, liver tonics. Then antibiotic to prevent the pneumonia or enteritis. Then avoid saline, especially whenever there is a severe anemic cases. So whenever there is a severe anemia, when proddy exudate is coming from the mouth or the salivation is there, in that case it's better to avoid salines to the sheep and goats. Now, prevention of all hemoprotozoal diseases, especially basically we should control on the ticks. So tick can be controlled by the dipping, spraying, giving the ivermectin. Then the cracks and crevices which are present in the farm, and whatever the breeding places of the ticks are there, that can be destroyed by either spraying with some chemicals, or by burning with the help of flame guns. Then destruction of tick breeding places by burning with the flame guns. Then by using chemicals, some cidal drugs like permethrin, cypermethrin, or any other which are commonly used for the destruction of the or the killing of the ticks. Then don't remove ticks manually from the infected animals. Why? Because there are 100% chance of relapse of the infection in spite of good treatment. So generally what happens, the peoples are, once they notice that the animals is infected with the theileria, they are just go to the animals and try to pick up all the ticks, and by the hand or by manually they are removing the ticks. In that case, there are chances of relapse of the infection, because whatever the pyroplasms are consumed by the that sheep and goat, with the pressure of hand or the fingers, there is a negative pressure or the extensive pressure over the abdomen of the ticks, and the same pyroplasms are injected through the mouth parts of the body of the ticks again into the body of that particular sheep and goat. So I will advise to don't remove the ticks manually. You can remove the ticks by giving injections like ivermectin. While the course of infection or the course of diseases course of treatment, we should avoid the removal of the ticks manually. Basically we should wait for some times, then give ivermectin injections, because till there is a presence of some pyroplasms in the body parts of the ticks, and with the pressure of the hand, there is a regurgitation. We can say the regurgitation of the blood from the body of the ticks into the body of sheep and goats. So there are 100% chances of the reinfection because of the removal of ticks by manual method. Now the another disease, that is the Babesia. Species which can cause Babesia is a Babesia motosi, Babesia ovis, Babesia capriole. The dermatocenter, Hemophysalis, Rhipicephalus are the ticks which can transmit the disease. This is many times Babesia is observed as a acute form of the disease, and no doubt it is also present in the chronic form. Why it is chronic form? Because in that case we are observing less than 1% of RBC remains infected for a longer period. So many times the questions will ask by the many pathologists that why there is a chronic Babesia. So the reason is that the chronic Babesia is there because there is presence of less than or the about 1% of RBCs remain infected in the blood, and that will lead to the extensive or the daily loss of 1% of RBC from the circulation, and that will called as a chronic type of Babesia in case of sheep and goat. Now it is characterized by the jaundice, enlargement of spleen, dark color kidneys, hemolyzed fluid in the body cavities, and pericardium. So these are the postmortem lesions which are commonly observed in case of Babesia. So here again, life cycle of Babesia similar to Theileria. The sporozoites will come to the general circulation in case of sheep and goat. These sporozoites will convert into trophozoites, then merogony will observe, and merozoites are released. Then again they will convert into the gametocytes, and from gametes the further progeny or the further multiplication of the Babesia can be observed, and this will be observed in the body parts of the sheep, and finally they will come to the kinate will come to the mouth parts of the ticks, and this from ticks there is a release of sporozoites, and the further life cycle of the Babesia is continuously going on in the sheep and goat. Now the postmortem lesions, the reddish fluid, the hemolyzed material which will observed in the pericardial sac. Similar type of material can be observed in the pericardial sacs. Here again, note same thing. Pericardium will have the whatever the, as we know, the Babesia is characterized by the hemoglobin urea. So in that case, the similar type of material can be observed in case of the body cavities, including the pericardial sac. Then kidneys are also intense in color, and we can see the renal pelvis will have the reddish type of material, or the hemoglobin urea, we can say. It can be observed like this in case of the renal pelvis in case of Babesia. In severe cases, there is a dark discoloration or the black discoloration of the kidneys can be observed. Sometimes we can see the kidneys are much more congested, and most of the portion of the kidneys are become reddish in color. The reddish or the reddish black type of material, reddish fluid, is observed in the abdominal cavity and thoracic cavity also. There is an enlargement of spleen too. Enlargement of spleen once again. Diagnosis of Babesia, it's based on the clinical science, that is hemoglobin urea. Then the postmortem lesions will helpful. Then blood smear examination, ELISA PCR is there, and we have to differentiate Babesia from the either phosphorus deficiency, water intoxication, poisoning, clostridial hemolytic infection, and leptospirosis. So in all these cases, there are chances of presence of one typical clinical signs, that is the hemoglobin urea. So based on the presence of presence of pyroplasm in blood, blood smear examination will be very much helpful in such type of conditions. So once we see the pyroplasm, once we see the organism of Babesia, they are present in the blood smear, definitely it will be the case of the Babesia, and ultimately we can go for the treatment of the same animal or the other animals based on the blood smear examination. So like this, we can observe the Babesia in the RBCs. The third case or the third disease, that is anaplasma. The species are Anaplasma ovis, Anaplasma marginal. Gallbladder shows hemorrhages, inflammation, and edema. These are the very typical clinical signs, typical postmortem lesions, and that is also called as a gall sickness in case of the anaplasma. But most of the times, anaplasma is very much complicated with the Theileria. So the pure case of anaplasma are rare to observe, but the subclinical cases of Theileria and the complicated cases of the Theileria along with anaplasma are very much common in the field conditions. The life cycle, half of the portion will be observed in the sheep and goat, and half of the portion will be observed in the body parts of the ticks. So here we can see the infected ticks, they are present over the surface of body. They release the organisms, and that organism will present over the surface of the RBC, and these RBCs will be removed by the mononuclear phagocytic system of the spleen, and ultimately the progressive jaundice will be observed in this case. And general idea about the anaplasma: many times it was observed that this anaplasma is remain as a subclinical type of infection. So usually it is a subclinical type of infection. About 35 to 60 days after infection of anaplasma, the anaplasma will remain in blood without showing any symptoms. So the animal anaplasma can be observed in the blood smear, but the animal will not have any type of fever or the icterus or the any other clinical signs. So anaplasma can be observed in the blood smear 15 to 36 days after infection in the blood smear examination or in the blood, and this will remain for these 36 days without causing any clinical signs. So it can cause clinical signs after 36 days. So it is obvious that blood smear may be positive for the anaplasma, but you will not get any clinical signs because of this dormant stage of this anaplasmosis. So 15 to 36 days are much more crucial, and within that period the animal show these clinical signs like wasting will be there, but no fever and no icterus is there. So but progressive wasting will be there. So this is one of the general idea about the anaplasmosis. Most of the times it is usually subclinical type of infection, and if it combined with the theileria, the progressive anemia and progressive jaundice will be observed in such type of mixed type of infection. A diagnosis of the anaplasma is based on the clinical signs, postmortem lesions, blood smear examination, ELISA and PCR. So these two academic type of interest are there. So we can go for the diagnosis of the anaplasma by the simply blood smear examination, and go for the postmortem examination. So blood smear examination will have anaplasma marginal or central can be observed. Here also again at the margin we can see the anaplasma. Then enlargement of lymph nodes is common in case of theileria as well as in anaplasma. Here again the enlargement of lymph node is there. Then typical sign or the typical postmortem lesion is the gall sickness. So gallbladder will have the hemorrhages, edema, and icteric type of alterations in the other tissues, but the gall sickness, the severe inflammation of the gallbladder is there, and if we cut open the gallbladder, we can observe the extensive or the severe inflammation of the wall of gallbladder. So these are some of the postmortem lesions of the different protozoal diseases in case of sheep and goat. Now, treatment aspect of the theileria. So theileria can be cured by giving buparvacone injection at the dose rate of the 2.5 milligram per kg body weight intramuscularly, and need to be repeated after 72 hours till you are not getting any pyroplasm in the blood smear examination. Then Babesia, diamagine aceturate can be given, or the Bernil can be given, imidocarb also given. In anaplasma also imidocarb can be given. Along with that, the secondary antibiotic which can be given, that is oxytetracycline 8 to 10 milligram per kg body weight IV for 3 to 5 days in case of theileria and anaplasma. In case of Babesia, the another important medicine can be used for the treatment is the phosphorus. Either you can use the elemental phosphorus, plain phosphorus, or the sodium acid phosphate. So it will prevent the lysis of RBC, and we are going to recover, or we are getting much more earlier recovery by providing phosphorus either orally or by injectable solutions. So we can get rid of from the Babesia, or we can stop the lysis of RBC along with the specific treatment of the Babesia. Then as a rule, as all these three diseases are causing reduction in hemoglobin, so our much more important duty is to provide hematinics, liver tonics in all these three cases. The hematinics should be given, liver tonic should be given. Then H2 blockers, in case of theileria, they are much more important because as theileria is causing the ulcerations in the abomasum, and to stop the ulcerations, stop the bleeding, we can give the H2 blockers like ranitidine, omeprazole, and nothing harm to give this H2 blockers in other treatment also like Babesia and as well as in the anaplasma. So it can be commonly used for the any type of feverish condition or the any type of infection. So but for the theileria we should go for the specifically we should provide the H2 blockers for the to prevent the abomasal ulceration and prevent the abomasal bleeding. So these are the some of the important aspect from the my side. Thank you very much.